Uh, Good evening, everybody. This is the night webinar. And I'd like to bring to you Dr. Kartavya Sharma. He passed his MBBS from All India Institute, went off to the US, qualified in neurology and intensive care, and now is a neurointensivist who's done his fellowship, runs his unit, and he's going to speak to us about hypoxic brain damage, predicting the future. Over to you, Kartavya.
All right, thank you. I want to start off by thanking Dr. Kothari and Dr. Gursahani for organizing this incredible forum. We were just talking earlier that it's amazing how we've achieved this across time zones with the number of attendees. And I guess if you wanted to make good use of this COVID-19 time, this is a good way to do it.
Yeah.
And so what I'm going to talk about today is in some ways specific to hospital neurology or ICU neurology, but the principles kind of apply across the spectrum of severe brain injuries. And so what I'll do is, because it's not just a hypoxic brain damage issue, it's more of a predicting outcome after any kind of severe brain damage question. I'll spend several minutes laying out what the issue is. This is a particular research interest of mine, and I've been kind of combing through the literature recently in order to update the guidelines for the American Academy of Neurology. But in the course of doing that, I've come across hundreds and hundreds of studies and abstracts, and I think I have a good sense of where the literature is headed in the field. And so briefly, the problem is that our role as neurologists, when somebody has cardiac arrest and they survive and they're comatose, which happens frequently, about 80% of patients after return of spontaneous circulation will be comatose. And so they'll often, if they don't wake up either immediately or in the next day or two, that'll lead to a neurology consult. And we will be asked whether we think the patient is going to improve or not. And that decision will pretty much directly impact whether the intensive care team stays aggressive with their care or not. And so it's kind of a big deal. 2/3 of these patients that have hypoxic ischemic brain injury will have brain damage after cardiac arrest. But what's interesting is that only a minority of these injuries will actually lead to brain death directly. The vast majority of those patients will die because of withdrawal of life support. And that withdrawal will happen because it will be determined that the patient was destined to have a poor outcome, a poor neurological outcome. There's in attending some meetings in the neurocritical care world here, it's becoming increasingly recognized that it's possible we're prematurely predicting poor outcomes, perhaps too soon or too frequently. And there is a chance that we are withdrawing life support on patients that would otherwise have done better if we just either waited longer or continued aggressive medical interventions. And so that's why the decision is kind of a big one. The data we use is very similar across countries and even across specialties. You'll use some idea of what the neurological exam looks like. You'll get some idea of what the scan looks like. You might get a biomarker or two. And you might do some electrophysiology studies like SSEPs or EEGs. And that's the information everybody uses. Ideally, what you want to do within that information is use pieces of data that have a very low false positive rate. And that's what I'm going to focus on a lot, false positive rate. By that I mean that when the test predicts a poor outcome, that nobody should have a good outcome that got predicted as a poor outcome. So that would be a false positive. And it would lead to an inappropriate withdrawal of life support. So in other words, the specificity of the test should be 100%, just because the stakes are that high when you make an incorrect prognosis. Briefly about the outcome I'm talking about is functional outcome, as we are quite used to in the world of neurology. Specific to the cardiac arrest literature is the cerebral performance category. This is a scale that's very similar to a modified Rankin scale when you see the actual grading of it. And the definition of poor functional outcome, it used to be a CPC of 4 or 5, which was a persistent vegetative state or death. But more recently, we've come to realize that perhaps a severe disability and being fully dependent and bedbound is perhaps as bad of a fate as CPC 4 and 5. And so the literature now focuses on CPC 3 to 5 as the definition of poor functional outcome for the most part. Same way that we use an MRS of 3 or more for, say, the stroke studies. Here's the problem in predicting, and that is that not everybody follows the same course of recovery. Patients can go from being comatose one day and to fully awakening the next day after cardiac arrest. Or some patients will have a much slower progression from a comatose state to a transient vegetative state, and the more recently described minimally conscious state, and then finally emerge, and that time course might be several weeks long. And it may not follow that linear course. You know, you might have periods where there's unresponsiveness and there's some responsiveness and then flipping back again. And so that makes it challenging to predict how things are going to go. And then secondly, just the biological substrate. Older patients versus younger patients have different brains. There's different levels of neurodegeneration, the ability to have plasticity after the brain injury, how much brain injury there actually happens during the cardiac arrest. All of those are variable across patients. So it makes it challenging to come up with some kind of formula to try to predict who's going to awaken, and more than awakening, who's going to have a good functional outcome. The AAN tried to do something like that in 2006, where I'm sure a lot of us might have seen this algorithm that was published that resulted from their synthesis of the data at the time. And you know, from the surface of it, it looks really nice and simplistic, kind of the perfect algorithm. You know, the way you want algorithms to be. You had this flow sheet where if you didn't have brain death, then you would progress to looking at these other signs. For example, on day 1, if a patient had myoclonic status epilepticus, then that was predictive of a poor outcome, and then the false positive rate was 0%. Or if that wasn't present, then if the SSEPs were absent in the day 1 to 3 time frame, that was pretty poor outcome. And similarly, NSC of 133, absent pupils or corneals, an extensor posturing response to noxious stimulus, or an absent motor response. So that would be a GCS of 2 and 1. And that was all great, except there's several issues that cropped up with the use of those guidelines. One is that therapeutic hypothermia became quite prevalent after those guidelines were published. And so it became questionable whether a lot of the markers we're using may lose their sensitivity because of the low temperatures. The NSC level, for example, you know, does it not rise as much because of hypothermia? Or the neurological exam findings, you know, do they get artificially suppressed because of the cold temperatures? And so that needed to be readdressed. Another complicating factor was that the actual data as it came in showed that, especially for the biomarkers, that the levels could be very widely variable and still be consistent with good outcome. And so the recommended thresholds came into question. For EEG at the time, the data was very limited, and in 2006, when the guidelines were published, the EEG literature would, you know, attempt to classify kind of groups of findings as malignant EEG findings and non-malignant EEG findings. You know, for example, status epilepticus or GPEDs would be considered a malignant finding, and it was all kind of put into one bin. The sample sizes were small, and so that didn't lead to good quality evidence at the time. And then finally, this risk of self-fulfilling prophecy, which I actually want to go ahead and spend some time on, because it is really, in terms of the cardiac arrest literature, it's the elephant in the room. What that means is that when we use a test, our test in this case being our exam, the scan, biomarkers, EEG findings, if we're using a test to predict poor outcomes, in order to do a study on whether that test is effective or whether that's a good test or not, you really need the treating team to not be using the test already to predict outcomes. In other words, if a treating team is using the results of an EEG to withdraw life support, expecting a poor prognosis, then when you do a retrospective analysis of that, EEG is going to look like a great predictor of poor outcome. And that is a problem that's pervasive in all cardiac arrest studies. It's very difficult to have a control group that where the treating team is blinded to the interventions, because of obvious ethical reasons there. And so the rider is that whenever you hear of a good predictive capability of a test, know that the literature that comes from is heavily biased by this self-fulfilling prophecy issue, and that needs to be recognized. With those problems in mind, the European Resuscitation Council in 2014 tried to address some of those caveats with more literature, more EEG studies. They actually graded the quality of the studies based on whether there was a risk of self-fulfilling prophecy bias, and they would downgrade study quality if that was the case. And as it turns out, 99% of the studies were low quality just because of that one reason. And so now I come to the data part of my talk. What I'm going to do here is sort of go through the data that ERC had in their synthesis of their recommendations. I'm going to identify some caveats in using that information in predicting poor outcomes. And then, being familiar with the more recent literature, I'll try to point out some trends that I'm seeing in this field, and you might expect studies to come out in the future about those trends. So roughly, I'm going to talk about neurological exam findings and predictors of examination findings, imaging, electrophysiology studies, and biomarkers. This is perhaps the easiest test that you can administer to gauge prognosis, because that's a bedside, it's quick. And typically when I do this talk, it's interactive, where I ask people what they think the statistics show. But I guess in this forum, I'll just go ahead and reveal the numbers. So starting with the most commonly used one, the pupillary light response, we'll often see that if the pupils are unreactive after cardiac arrest, that's a very ominous sign that portends a very poor prognosis. And so pupillary light response being absent after cardiac arrest, immediately after, when you have return of spontaneous circulation. It turns out that the false positive rate, which means that if 100 people had absent pupils, how many actually have a good outcome? So 8% in the studies that we have so far, 8% will have a false positive. And what I want to focus on as a statistical exercise is not so much the point estimate. The point estimates are important because they come from the actual cohort that's being studied. But what's perhaps more important is the confidence interval of that estimate. Because that is a guess of what the real value is based on the study that gave us the point estimate. And so although the false positive rate is 8%, the confidence interval is 1 to 25%. So it's possible that up to 25% patients may have a good outcome if you see an absent pupillary response immediately after ROSC. So not a very good predictor, and should probably not be relied on immediately after spontaneous circulation is achieved. How about after 72 hours? So if you have absent pupils after 3 days, that false positive rate, the point estimate goes down to 0. So and it turns out is a pretty robust predictor of poor outcome. You'll see the confidence intervals is 0 to 8%, and because that takes into account the sample sizes that gave you the point estimate, and if they're low, then the confidence interval will increase. Corneal reflexes being absent at 72 hours, about 4% false positive rate. Absent eye movements, it on the outside looks like a good predictor by the point estimate. If you look at the confidence intervals, it's very wide. It's very small groups of patients that have been studied. It can have up to a 41% false positive rate based on the literature we have. And so this has pretty much been abandoned as a predictor of poor outcome. And for those of us who actually do these consults, it's actually kind of challenging in post-cardiac arrest comatose patients who are intubated to have a robust assessment of eye movements, you know, when you're trying to kind of jerk the head when they're intubated. This doesn't work out. So it's not used both in the guidelines and even in my experience practically. The GCSM, so the motor response to pain of extensor, the two or less would be extensor or absent to noxious stimulus. This was recommended in the guidelines as a way to assess for a possibility of poor outcome. But as the literature has piled up, it turns out this is a horrible indicator of poor outcome. The point estimate is 27% false positive. The confidence interval is up to half of the patients. And this is terrible. This is almost like a coin flip. And so this, I would advise, if you've been using it, to stop using GCSM as a predictor of poor outcome by itself. In combination with other findings, it might have some additive value, but by itself, it's a terrible predictor. A presence of myoclonus after cardiac arrest in the first 3 days has a point estimate of false positive rate of 5% and a confidence interval of 3 to 8%, which is actually not bad. Not as good as absent pupils, but decent performance there. How about status myoclonus in the first several days? That seems like a good predictor from the outset. The point estimate of 0 and a pretty narrow and close to 0 confidence interval. The problem with status myoclonus is that in my going through the literature, I see report after report after report of good outcome after early status myoclonus, which is the kind we think is, you know, predictive of poor outcome, as opposed to a later status myoclonus, which we think is Lance-Adams syndrome and perfectly compatible with a good outcome. And so I see this concerning trend of these case reports, and I think that might have to do with the caveats associated with these exam findings, with using these exam findings, and that's the self-fulfilling prophecy bias. Pupillary responses being absent and the presence of status myoclonus, it's a very visceral kind of an appearance when you do an exam and you see these findings. It's very, very hard to ignore and very unsettling when you see them. And so we've always used that as a poor predictor, even before we did these studies. And there will never be a study where you can allow treating teams or ICU teams to continue life support, even though they're seeing pupillary responses being absent day after day after day. Therefore, these predictors do look great, but just be aware that they're also very susceptible to that self-fulfilling prophecy bias. They've been predictors of poor outcome even before there were ventilators. The other aspect of myoclonus specifically is we don't really know electrophysiologically what it is. You know, we try to classify it as, you know, cortical or subcortical or even brainstem, but to be honest, we don't know what it is the way we know what perhaps seizures are. There've been some attempts to try to subclassify the kind of myoclonus based on the EEG findings. It looks like perhaps myoclonus associated with burst suppression or high amplitude polyspikes may have a poorer prognosis than myoclonus which has a continuous background with or without vertex sharp waves. That kind of myoclonus might be compatible with a favorable prognosis, but the literature isn't robust enough to, you know, be certain about that. Some trends I'm seeing in reviewing these studies is that first of all, using these predictors of exam predictors of poor outcome within the first 48 hours is unacceptably high false positive rates. For pupillary light responses, more and more intensive care units are using pupillometers to increase the sensitivity of actually detecting a light response so that it kind of reduces the false positive rate. And then finally, use of EEG to kind of try to subclassify myoclonus as a more malignant versus a more benign kind of myoclonus. I'm seeing that there are studies coming out trying to do that. Moving on to electrophysiological markers. So SSEPs, which is your N20 response after stimulating the median nerve. SSEP is done within the first 72 hours after cardiac arrest. Has a pretty good performance, actually, a false positive rate of 0 point estimate and very narrow confidence intervals. In that last column over there, I've tried to communicate what the sample size was used by the guidelines to generate these point estimates. And you'll see, a good 1,000 patients were, 1,100 patients were enrolled in the, not enrolled, but the data for 1,100 patients was looked at, out of which 285 patients actually had the absent SSEPs. The EEG being non-reactive to external stimulation is another poor prognostic sign that we've tried to use in the past. And so doing that at around the day 3 mark gives us a pretty good estimate for false positive rate, which is very no false positives in the literature with narrow confidence intervals. But I do want to point out the sample sizes that we're getting down. Now we're getting down to, with the EEG study, we're getting down to 200 and even less than 100 patients that this data comes from. So in terms of recommending to the whole world what the guidelines should be, that's very low standard to use to make any sweeping recommendations about using it. Status epilepticus, electrographic status epilepticus in the first 3 days after cardiac arrest. We have a false positive rate of 6% if you use that finding alone. And the confidence intervals are quite large, it's 1 to 20%, probably stemming from the small sample size that was used to generate that estimate. And also perhaps, we don't really know if perhaps treating the status epilepticus improves outcomes or not. A burst suppression pattern after 3 days of cardiac arrest seems to have a good prognostic performance, narrow confidence intervals, small sample size, as you can see again, 95 patients only, of which only 7 had burst suppression. And then low voltage EEGs has not that great of a performance in terms of predicting poor outcomes, 6% false positive rate. Small sample size again, big confidence intervals. Here are some caveats to using SSEPs. SSEPs, being a poor prognostic marker, also predates the use of ventilators. And so they've always been used as a sign of poor outcome. Almost no studies will exclude or allow treating teams not to have access to the SSEP results. The other problem with SSEPs, besides the self-fulfilling prophecy bias, is that the interpretation of them by themselves, the inter-observer concordance between 2 different like neurophysiologists is very poor. It's 0.2 to 0.65 in one study. And so you can see how that might lead to, if one says that SSEPs are absent, but the other says that the study is too poor quality and it's either uninterpretable or maybe it's present, and then how that could lead to false positive occurrence. And what makes me a little more concerned about SSEPs are that the more I go through, kind of comb through these studies for my research, I keep finding tables like these where, this is a cohort of patients that they looked at and they wanted to see what the NSE levels look like in terms of predicting poor outcomes. But on this row, if I could drive your attention to, you'll see absent SSEPs in their cohort, 43 patients had, of which 3 actually had a good outcome, which, for a false positive rate of 0 is kind of not consistent with what the recommendations are. Here's another study, similar issue, bilaterally absent SSEPs at 72 hours. They had 7 patients who had that finding who actually ended up having a good outcome. That's a very big number from one center. And so whether that's because they didn't use it as a predictor for withdrawing life support, or maybe they just misinterpreted because of the poor inter-observer concordance. It's not really stated in the studies. Here's yet another one, same issue. This is a cohort in cardiac arrest patients where they had absent N20s and SSEPs, and they actually had 6 patients who had a good outcome. CPC of 1 or 2 is a good outcome despite having absent SSEPs. So just a concerning trend, but in general, SSEPs seem to be, other than that, a robust predictor of poor outcome. The issues with using EEG currently, at least up until the 2014 guidelines, was that the definitions of status epilepticus of burst suppression were widely variable. The status, one study would use electrographic seizure activity for more than 5 minutes, another would use it for more than 30 minutes. One study would use GPEDs as the criteria for status epilepticus. Another would say GPEDs above a certain frequency, more than 2.5 hertz or something like that. And so it was very hard to combine the data and say, well, status epilepticus is a predictor or not. And that applies to burst suppression as well. The definition of the burst and the definition of the suppressions were different. The sample sizes, as you can see, are very small that the data and the guidelines in 2014 come from. And then there's some evidence that perhaps a one-time EEG is not as good as just using a longitudinal EEG analysis and seeing if the suspected malignant findings, if they resolve over time, that might be a better marker of outcome than just using that finding at the same time point. One saving grace is that the ACNS, American Clinical Neurophysiology Society, came up with some standardized critical care EEG terminology in 2012. And I've seen that that has been quite rapidly adopted in the critical care EEG literature, and it's much easier to actually combine studies when doing a meta-analysis now. And so you might expect findings to be reported in upcoming future guidelines. Some trends here, besides the use of longitudinal EEG, is that the terminology is consistent, and it looks like the electrophysiological, the EEG markers seem to have a good prognostic performance, some of the individual ones. Don't hold me to that yet because the analyses haven't been done, but in just my reading of the studies, I'm seeing more and more reports of EEG being useful in predicting outcome. Coming to neuroimaging findings, here's where the literature becomes really messy, actually. CT scans are done almost universally, at least in the United States, after cardiac arrest. And if the patient is comatose, they'll almost certainly get a CT scan to look for other causes of coma, like a subarachnoid hemorrhage or looking for cerebral edema and seeing if we need to treat it. And the main finding of anoxic brain injury is cerebral edema, sulcal effacement, and loss of kind of the gray-white matter interface. And while visually you can kind of guesstimate these findings, and most of these scans are done right after return of spontaneous circulation without return of consciousness. Here's, this is probably not necessary for this audience, but here's an example of a normal CT scan, and here's one that shows diffuse cerebral edema. You see that the lateral ventricles are pretty much effaced, and you'll notice the conspicuous kind of lack of appearance of the basal ganglia, which attests to the loss of gray-white matter interface. And so while you can do this visually, using this as a data point and making recommendations becomes quite tricky. Some studies have tried to calculate using Hounsfield unit measurements of gray matter structures and white matter structures, and using a ratio to see if there's a certain cutoff below which the false positive rate drops to 0. And that, by the way, is the statistical kind of setup for most of these neuroimaging studies, is where you would have a cohort, you would do an imaging test, and you would look at a finding, and then you would try to find a cutoff in your imaging finding which doesn't have any false positives. And so, for example, here, these 3 studies looked at gray-white ratio using Hounsfield unit calculations, and for a false positive rate of 0%, the threshold was different amongst the studies. And that's the problem with CT literature. And that is that the appearance of gray and white matter in the Hounsfield units varies by what kind of scanner you use. The visual appearance actually varies by the kind of screen you use to look at it. And so it's very difficult to combine data and recommend a certain cutoff, which is predictive of poor outcome. The other thing is you'll notice the confidence intervals are quite wide. And so even though the point estimates are 0, you still have low confidence that that's a true value for a gray-white ratio. So as I mentioned, the caveat is that the appearance can vary with the scanner and the imaging parameters even within the same scanner. The timing is kind of an issue as well, because as we know from the stroke literature, after ischemia, for the first several hours, the Hounsfield units will consistently decline. And so if you do a scan immediately after ROSC versus after 4 hours after ROSC, the gray-white ratio is likely to change. And so what time point do you actually recommend using? It's a problem. And then finally, there's findings that can artificially change the artifacts that can change the ratios irrespective of time. Dilated perivascular spaces or chronic microvascular ischemic disease. It can make the basal ganglia density be reduced, and it can make it look falsely low. The gray-white ratio look falsely low. And on the flip side, leukoariosis may look, the white matter look quite dark, and it can pseudo-normalize the gray-white ratio, even though there is an oxic brain injury. And so something that perhaps using MRI would be a better solution and a better way to look at the extent of damage and maybe a better predictive performance. But MRI is also kind of plagued with the same problems in terms of being able to collect the studies and make recommendations. The most common finding you would look at in MRI is hyperintensity on DWI sequences. And the ADC is a quantitative measure of those DWI changes. Normal ADC values would be 700 to 800 times 10 to the power minus 6. And so the way the studies have tried to tackle this is similar to CT scans. They would look at an ADC sequence, and you come up with some measurement of the ADC, below which you have a false positive rate of 0. So if you have a reading below that level of ADC, then you can say, well, this is a poor outcome without any exceptions. But as you see here in collecting some of these studies, the actual criteria they use is different for every study. You know, one example is this Christine Wyman study from Stanford, where they looked at the ADC of less than 650 times 10 to the power minus 6. They looked at the voxels that had this value and calculated the percentage of those voxels as a percent of total brain volume. And they found that if more than 10% of the brain had ADC values below that number, that the false positive rate of predicting poor outcome was 0. So a decent predictive performance. And you see the confidence intervals are wide, it's 0 to 78, because this was a pilot study. They've since done a follow-up to that study with a bigger sample size. And on that study, it shows that a ratio of 25% is what predicts a false positive rate of 0. So you see how dramatically the real estimate changed. And that's where the confidence intervals comes in, because the confidence intervals are really what we think the real value is just supposed to lie between. You'll see some of these other studies, you've used widely different criteria to look at the ADC. You know, this study looked at the ADC in the occipital cortex and the putamen. This one looked at ADC similarly in the occipital cortex and the putamen. They came up with different cutoffs for how low the ADC should be to predict a poor outcome. This study by Wee in 2009 looked at whole brain ADC, just averaged all of the voxels, and if the average was below this number, it predicted a poor outcome. And so, you know, how do you combine these findings into some kind of a coherent recommendation? And another problem is that the way that they calculate these values, the way they define their region of interest, or the way they pick their voxels, requires either manually delineating what parts of the brain we're measuring, or using some kind of automated software to reject artifact and delineate the cortical structures to measure ADC values. And those methods are all different between studies. And also not kind of clinically viable, because you know who's sitting at a scan and using a software to parcellate these into the appropriate mask, and then calculating ADC values and calculating the ratio. It's just not practical currently. The timing for these scans across the studies have also been variable. You know, there's some thought that perhaps cortical tissues, it might be best to measure the ADC for them earlier, a 3 to 4 day mark, than subcortical structures, which seem to have their lowest ADC values around the 6 to 8 day mark. And so timing of these studies is kind of a problem. Sample sizes are small because of just the technically difficult nature of doing these MRI studies in cardiac arrest patients who are, you know, on ventilators almost all the time. And then finally, there's some bias built into MRI beyond just self-fulfilling prophecy, and that's just the decision to get the scan itself already screens out patients who are improving, and so arguably patients who are not improving are the ones that end up getting MRI scans, day 4, day 5, or the week mark, and so whatever findings you see on the MRI might they will be associated with a poor outcome, but it might be because the population was picked that way. Some of the trends in the literature are that obviously the sample sizes are increasing as is required, but people are looking at other MRI-based parameters like cortical thickness and the presence of specifically the hippocampus in predicting, in making some of these calculations. There's one study that tried to come up with a scoring system where they would assign numbers to the number of lobes, individual lobes and insula involved, assign it a score based on the ADC cutoffs, and then try to add them into some kind of a global score and see if there's a score cutoff that you can use to predict poor outcomes. And so that study is there, and it has a cutoff which has a false positive rate of 0. But then again, the same problems stand: the timing of the scan, how do you pick that? The software they use to find the regions of interest, it needs to be same software. And then finally, functional MRI, looking at resting state networks in some of these post-cardiac arrest patients is, I'm seeing at least 2 or 3 studies that have looked at that. And it turns out that perhaps the presence of intact resting state networks in these patients may be a predictor of actually improved outcomes. The caveat is the samples are small and the studies are technically challenging to do. And then the last category of predictors we are familiar with using, those are the biomarkers. The more common ones we're probably all familiar with are the NSE, which is a neuron-specific enolase, supposed to be a marker specific to neuronal injury, and S100 beta, which is supposed to be a marker specific to glial cells. And from the 2006 guidelines, there was an NSE threshold of 33 micrograms per liter. And if the levels were higher than that in the first 3 days, then that was supposed to be a predictor of poor outcome with a 0% false positive rate. But as I said before, it turns out that that's not really true. And subsequent studies have shown that that cutoff can be all over the place. Especially if you look at this one at 48 hours, a cutoff of 151. You could still have a patient with a good outcome with that level. And so an NSE cutoff can simply not be and should not be used or recommended anymore based on this literature. S100 beta, the literature is much smaller because it's a marker that's being used more recently compared to NSE. But the problems are the same, where there's various studies that look at the markers at various time points, and they come up with a threshold that has a false positive rate of 0, but then the thresholds end up being different, and the sample sizes are small. Some of the caveats to using NSE, in addition to what I mentioned, was that the measurement assay itself, this was very surprising to me. There was one study that compared the assays existing in the United States that we use for NSE levels, and we had about 7 assays. The 7 assays were statistically significantly different from each other for the same patient sample. And so a level you get from one may be widely and statistically significantly different from another one. And that is a big problem in being able to use NSE. There are extra neuronal sources of these markers. For example, hemolysis can cause release of NSE, which sometimes can happen with cardiac arrest, especially if the cardiac arrest is after a trauma. Same for muscle and adipose tissues, can release some degree of S100 beta. And the kinetics of these markers in terms of how fast they rise and how quickly or how late they dissipate and at what rate they're metabolized is not very clear. And therefore, recommending an ideal time to check these has been very difficult. And so the literature that's being described currently is interested in looking at one trends. So in the case of NSE, it looks like more than one study has shown that perhaps a rise in the NSE over a day or two is a better predictor of poor outcome than just a single high cutoff. There's one study that compared S100 beta with NSE, and they seem to think that S100 beta seemed to have a better prognostic performance in the first couple of days, and NSE had a better performance on day 3 and 4. And then there's some studies that are combining the two and seeing if perhaps predictive performance, if used in some kind of a formula where you incorporate both levels, might be a better predictor of poor outcome. And so that's being looked at. There's some smaller studies looking at novel biomarkers like serum GFAP and NGAL, neutrophil gel elastinase, and they have various rationales for using these markers. Part of it might be just that their lab has the ability to check the marker. Brain-enriched microRNAs, and there's at least one study that's looking at just a transcriptome in the CSF after cardiac arrest and seeing if there's a biomarker that sticks out that seems to be predicting improvement in the patient's condition. And so with that, I'll wrap up the current recommendations as they stand based on the evidence that's been synthesized up until 2014-15. The trends that I've mentioned have not yet been incorporated in any practice parameters or guidelines yet. And so as things stand currently, the recommendation is to use a multimodal prognostication whenever possible. So try to avoid using one single finding and hanging your hat on that to predict poor outcomes. The time points that are recommended are in the first 48 hours, CT head findings, status myoclonus, pupils and corneal reflexes, and the SSEPs can be checked and utilized as a data point in developing the prognosis. On day 3, EEG findings and NSE levels can also be used. And perhaps MRI should be reserved for a later time point to allow for the ADC values to actually nadir. And so day 3 to 5 would be an ideal time frame as things stand currently for using an MRI in your prognostic estimate. The opinion, kind of the unofficial opinion, is quite clear that the prognostic assessment should really be delayed if possible up until 72 hours. As much as possible, obviously contingent on how much critical care is being utilized or how sustainable it is to sustain the patient that long. But ideally, one should wait 3 days before putting all of these data points together. You can obtain the data points before, but perhaps wait till day 3. And so pupillary and corneal reflexes being absent or SSEPs being absent at 72 hours by themselves seem to be very robust predictors of poor outcome, keeping in mind the caveats that I spelled out earlier. If those findings are not present, then you could use a combination of findings, 2 or more, and the 2 preferably should be different classes of evidence. And so between exam findings, electrophysiology studies, imaging findings, and biomarkers, it's best to rely on 2 categories of predictors and putting them together to make a poor prognostic estimate. And so those that seem to have good evidence are status myoclonus, that's early, within the first 48 hours post-ROSC. On EEG, if you have an unreactive background with burst suppression or an unreactive background with status epilepticus. Evidence of diffuse anoxic brain injury without getting into any kind of cutoffs or measurements. So if the evidence of diffuse anoxic brain injury on imaging, and then a high NSE level, and there's no recommendation for a certain level to look for, but perhaps a reasonably high NSE level, much higher than 33 is my recommendation, can be used as one of those pieces of data that you could use to combine and predict poor outcomes. I don't know if we have time for this. I had a case that I wanted to go through to illustrate some of these challenges. Dr. Gursahani, are you there?
Good.
Are we good on time? Can I spend 5 minutes and kind of laying out this case?
Yeah, absolutely. Go ahead.
Okay. So this is a patient we've seen in our critical care unit this is an 18-year-old woman who has asthma, and she has known severe recurrent exacerbations. She, was playing with her kid outside, and all of a sudden became blue in the lips, had this acute attack, collapsed, and her brother couldn't find a pulse, and he started bystander CPR right then. The emergency medical services arrived 4 minutes later, and they achieved ROSC in an additional 8 minutes, required epinephrine and a bicarb administration. When she came, she was comatose and therefore met criteria for the hypothermia protocol. At the time, we initiated temperature of 33 Celsius. The more recent data is that 33 and 36 might be equivalent in terms of their neuroprotective effect. We did it with 33 Celsius at the time. We continued to have trouble ventilating her despite using steroids, nebulizers. We used Heliox, propofol. We used an epinephrine infusion, and we could not get her asthma, the obstructive lung issues to improve. And because of persistent problems oxygenating, we instituted, and this was this whole ordeal was a 5 to 6 hour ordeal before we could actually start veno-venous ECMO to oxygenate her blood extracorporeally. And so she remained comatose. They called, the neurologist got involved, and we tried to come up with a prognostic estimate. And so her exam findings on day 3, this is after the hypothermia protocol has been removed, was that her pupils, they seemed unreactive when you used a flashlight, but when you actually checked with a pupillometer, they were reactive, both sides, very, very minimally. The corneal reflex was present bilaterally, and the cough and gag reflexes were present. Notice how I don't mention the motor response because, as it stands, it's quite useless in predicting outcomes in an oxic brain injury. Here's her CT scan. You'll notice the diffuse cerebral edema, the collapsed ventricles, the lack of a definition in the basal ganglia. So evidence of diffuse anoxic brain injury. We did, after this scan, we started some hypertonic therapy to address what we suspected would be a high ICP and to try to reduce the cerebral edema. And on a subsequent scan, we saw that maybe the ventricles seemed a little more prominent. We started seeing the appearance of sulci a little better. So we thought we were making progress in treating the edema. She remained comatose. And so we got an SSEP on day 3, which was present bilaterally. And we got an EEG on day 6, where the posterior dominant rhythm was obviously not seen. It showed diffuse slowing. There was no EEG reactivity. And it showed intermittent bursts of delta activity, which was diffuse but bifrontally predominant. So kind of a generic severe encephalopathy picture with a non-reactive background. On day 6, we got another CT scan because she's still comatose, and you're seeing now that there's evidence of bifrontal infarctions. The basal ganglia are almost invisible now. Ventricles are still collapsed, and so there's still ongoing cerebral edema. It actually looks worse than the first scan that we had. And so this is the time point where a lot of intensive care units would call it a day, because you've had evidence of severe brain damage on a scan. You have clearly multifocal infarcts. You have unreactive EEG. And so you could say that the evidence points to a poor outcome, and then, withdraw life support, and what will happen is a self-fulfilling prophecy, which is the patient will die because we think that she had a bad outcome. But when you actually go through the data that I just spelled out, you'll see that she doesn't really have any of the robust predictors of poor outcome. Her pupils are present, her SSEP is present. Some of these other findings are more soft calls, so having some diffuse anoxic brain injury on imaging, having an unreactive EEG, they are soft findings, and in combination, they do increase the specificity of predicting a poor outcome. But in her case, she's also very young. We decided to keep going, given that these were kind of soft signs. So we placed an intraparenchymal ICP monitor. This is not guidelines based. This was something we felt we needed to do to be able to titrate the hypertonic therapy. She had to continue to be on VV ECMO for another week or so, and then after the ECMO was removed, we still couldn't stop the sedation because she was having issues with ventilator compliance and high peak pressures. And so she remained heavily sedated for 3 weeks. We got an MRI in the second week, and that basically confirmed evidence of diffuse anoxic brain injury. You'll see infarction in the occipital lobes, the basal ganglia. And on day 45, this is after discussions with the family and telling, we spelled out that the prognosis was quite guarded and likely poor, that she was discharged to a coma stimulation program on day 45 and still in a comatose state. However, at 6 months, she's awake, she's in a wheelchair. She has a spastic hemiparesis, but she is oriented, she communicates, she has dysarthric speech. She recognizes her family member, she recognizes her child, she can talk. She also knows what's happened to her, so cognitively actually not that bad. And the family actually couldn't be happier. They've contacted us multiple times to express their gratitude, both to us and the coma stimulation, the rehab program that she went to. And so this is, I wanted to use this example as an example of how to use these guidelines. When you have these soft signs, but you're not sure, it's perhaps best to increase the time frame for observation to allow for the prognosis to declare itself rather than provide a falsely poor prognosis. I have to point out lastly, and that is the outcome measure itself. I remember how CPC of 3 to 5 or MRS of 3 to 5 is considered a bad outcome. In her case, because she's wheelchair bound and hemiparetic, this would be considered actually to be a poor outcome based on those scales. But when you actually talk to her and her family, so when you actually use a patient-oriented outcome measure, they're really thrilled with the fact that she can do even that. And so there is perhaps a disconnect, or sometimes there is. You'll notice when you're talking about prognosis with the family, so there's a disconnect between what we are trying to predict and what the family would be okay with. All right, I think that's the end of the talk, and I'm happy to take any questions.
Right, so I'm here. And what I'll do, that was, thanks for bringing us up to speed on how all of this literature is panning out, because some of this was or has been a little difficult to kind of understand. And what I'm going to do is, there are some questions that I have, and I'm going to put them up on a PowerPoint. And if you can stop sharing your screen, I'll bring up my screen.
Okay.
Yes, so now I will share my screen. Here it is. Right. So can you speak a little bit about therapeutic hypothermia versus targeted temperature management? Because, it's not something that is uniformly done in India across ICUs also. So we need to know a bit about that.
Sure. So just to start off with the actual terminology itself, that is basically old versus new. It used to be called therapeutic hypothermia when we were targeting low temperatures, 33 Celsius. But the more recent nomenclature is to use targeted temperature management, and that stems from the TTM trial, which looked at patients with cooled to 33 degrees Celsius versus those cooled to 36 degrees Celsius. And for the 36 Celsius group, sometimes the patient didn't even require cooling. Their body temperature was just that spontaneously. And so it turns out that the improvement in neurological outcomes that you get were similar across the groups, i.e. there was no difference in the groups in terms of neurological outcomes in this study. Therefore, the push now is to just call it targeted temperature management, because targeting a temperature of 36 degrees Celsius, which patients can do sometimes by themselves, seems to be sufficient to afford that little bit of neuroprotection. That being said, that problem also exists here, where the targeted temperature management is not uniformly initiated. And that has to do with, in my experience, with self-fulfilling prophecy. And at least in the centers that I've worked at, and now UT Southwestern, Johns Hopkins, and University of Kansas, combining all three together, my experience has been that when the prognostic estimate, when you do it too early and you suspect that outcomes are poor, often the TTM step would be not taken.
Oh, really?
Because when you do TTM, you're committing to 24 hours of cooling, 24 hours of rewarming. And so you're committing to ICU care for a minimum of 48 hours if you do TTM, which is what the recommendations are. Actually, JACO tracks outcomes here for cardiac arrest patients. And one of the performance measures they look at is how frequently targeted temperature management was initiated in comatose patients. And it's a problem that it's not uniformly being done. I think it should. There are skeptics of the literature where people don't really think that it does anything at all. People just think, oh, maybe just avoiding a fever is really what's improving outcomes. We're not really changing outcomes much by cooling patients, and so why bother? That is a valid opinion and it's being investigated, but in my mind, until there's a formal guideline or robust evidence that that's the case, it's probably safest to do the TTM than decide to not do it because of an opinion. And so until the literature changes, I would recommend that TTM be uniformly initiated in post cardiac arrest patients who are comatose.
Yeah,
in order to improve their neurological outcomes.
I know, because of the two ICUs that I see, one implements it fairly strictly and the other doesn't.
Right.
Obviously, I mean, as a neurologist, you end up going there and finding out what they've done rather than being able to tell them what. I'm going to go to the last question because that's from Sudhir Kothari. As a clinician, when is the earliest one can give a good or a bad prognosis? And what would be the combinations of investigation, signs, symptoms that you would insist on having? I mean, if you were...
I wrote it in short, but what I wanted was, I mean, of course, on day 0, I mean, hour 0, your signs would differ. After 24 hours, the prognostic thing will differ. So how do you go about it from time to time? So
I mean, let me put it this way, that you ignore the economics of it. Okay? Ignore the economics.
Absolutely.
You do it in terms of science. When is the earliest that you would...
Absolutely. So that's, I was going to say that I'm glad you qualified that. So if you were to just use the literature and ignore other things, the economics of it, perhaps you have a really old patient who has wishes to not, want to go through any degree of critical care for an extended length of time. And thirdly, the actual logistics of keeping a patient alive actually in the ICU after cardiac arrest. Most of them are really ill. They might have heart failure or fulminant hepatic failure, and they might be on dialysis, or they might be on all of those things. And so keep putting that aside as well, purely from a neurological standpoint, because when they get a neurology consult to ask you what your prognosis is, they're really not asking you what the global critical care picture is and tell us, what's practical to recommend. That's really not the question. The question is, from a brain standpoint, what do we think the prognosis is, assuming that the other problems were not a factor. So if that's the case, then the literature would suggest that you wait about 3 days, so 72 hours. Most definitely allow the TTM period to be passed, so 24 hours of TTM, 24 hours to allow for rewarming, which in the era of 36 degrees Celsius actually doesn't really take 24 hours. And to allow for these imaging findings to actually develop changes. The robust signs based on the literature that you can use are absent pupillary and corneal reflexes and absent SSEPs within the first 3 days. If those are absent, the current literature would support using that as a decision point, even one of those findings, a decision point to predict a poor prognosis.
So when would you do an apnea test?
An apnea test? Well, so brain death would be a different issue. So we're talking about people who did not end up being brain dead, who are comatose, and now you're supposed to predict if they're going to get better or not.
Yeah, so the pupils are reacting and the patient is breathing. We are talking
Right.
about...
Correct. Or, you can have unreactive pupils, but not brain death in anoxic brain injury. And that happens infrequently, but it's possible.
No, but I still, I mean, I'm still going back. And I'm going back to, say, the first 3 days.
Mm-hmm.
Okay. You may or may not have done hypothermia. You're into the second or the third day. and well, somebody is asking you for a prognosis, and this patient is still GCS3.
Right.
Would you go ahead and do an apnea test on day, say, 2 or day 3?
You could, as long as the prerequisites for apnea test are met, and the AN has some guidelines as to what those
We follow
prerequisites
those.
are. Normal core temperature, the sufficient amount of time for the sedatives to wear off, and no paralytics and stuff like that.
None. So 72 hours.
Yes, yeah, you could do that at any time as long as the prerequisites are met. And at that point, it's not really a prognosis question. What you're, in essence, doing at the time is seeing if the patient is dead or not when you're doing a brain death exam. So if they're not brain dead, then you can come to the question of now what's the prognosis? Are they going to improve or not? And that's where some of this testing comes in.
And what is the longest that you would hold this diagnosis? Because for me, as a clinician managing these patients, the issue really comes up of when do you convert the intubation to a tracheostomy? Because from the intensive care side, there is always this push. Put them on a tracheostomy and move them out of my ICU.
Right.
But once you put in a tracheostomy, then you cross the point of no return.
I know that, and I wish I could spell this out in terms of a recommendation for you, but that's where the clinical judgment part comes in. But what I'm trying to communicate is to not use the evidence in a false way, because what I see frequently happening is that when we're counseling families about, whether we think that the outcome is going to be poor, will frequently, not me, but people who aren't familiar with the literature will frequently say something like, it's been 5 days or it's been 7 days, and there's been no signs of improvement. The scan looks bad, and there's no chance that they're going to get better. That's typically what will be communicated to a family in order to proceed with withdrawal life support or decide to continue going, and that's incorrect because the literature doesn't support that prognostic estimate. So the discussion of whether to continue life support now becomes a practical one. So now what you say is, well, the prognosis is indeterminate. Knowing that, here are the practical realities of what's happening. They might be very aged. They might have several comorbidities that prevent them from having a good quality of life anyway, even before the cardiac arrest. Now you're talking about what should be talked about instead of giving a falsely negative neurological prognosis. It's somehow easier to do that than it is to actually talk about the practical realities of what's happening. And in my experience, and obviously working here, most families do understand that we cannot predict, because you may come to a point where you have brainstem reflexes, you have not much neuroimaging damage, yet your patient's in a coma, and it's been 7 days since their cardiac arrest. And so the answer is that we really don't know the prognosis. That it could be good. There's no poor prognostic sign there.
So a couple of other things, and this is one is how often do you use continuous EEG for these patients?
If I'm doing an EEG, I'll do continuous EEG. There's
how long?
This has. Can you hear me?
Yeah. How long?
So 24 hours is what we typically do, and that has to do with two reasons. One is practical, and that's because 24-hour period gives you, between assessments for a consultant, it gives you a good time frame to look at the temporal course of findings. And the second has to do with billing, is the way the EEGs are billed over here. They're billed in either as a spot EEG for 30 minutes, or you could do a 6-hour EEG, or you could bill for a 24-hour EEG.
Okay.
And so you bill in increments there. So if you end up doing a 16-hour one, then you don't really qualify for the next higher level of billing. So you might as well just complete the
okay.
monitoring.
So maybe not relevant everywhere. Okay, and
but 24 hours for practical reasons as well is what I typically do.
And when would you said you would do the MRI at about 5 days? That's
3 to 5 days is when you would do it, and depending on how soon you want to have your prognostic estimate.
Okay, then there was one more question on the use of topiramate, amantadine, zolpidem, all those drugs that I use. Mainly they're used in rehabilitation and for the persistent vegetative state. So I guess.
That's correct. So the literature, I don't know about topiramate, but certainly exists for amantadine and zolpidem.
Yeah.
And zolpidem paradoxically seems to increase activity, thalamic activity, and that's how we think it's used. And amantadine we think may stimulate the reticular activating system at the brainstem level. And so the rehab literature is actually not in anoxic brain injury; it's in traumatic brain injury. But the principles that or the basic science that they used to pursue those trials was the same. Should apply to anoxic brain injury as well. But there aren't studies that have demonstrated conclusively that they work well. There are studies in TBI.
Okay. I think there are a few more questions, but yeah, this is one that does interburst interval or duration of burst suppression, I mean, the duration of suppression have
Excuse me?
EEG using interburst interval or the duration of suppression in terms of the EEG significance? I'm not sure if that really is different.
Are they asking if the interburst interval actually has any bearing on whether it's a poor prognostic sign or not?
Yes. Can you see that question?
I can't.
Okay, this question I'll just read it out. Does interburst interval or duration of suppression have which of these two has more significance on the EEG for prognosis? I'm also
currently the literature does not look at interburst interval specifically as a continuous scale. So I guess the hypothesis there would be the longer the interburst interval is, that's suggestive of a more suppressed EEG. And along that continuum, you could have short interburst intervals, and the most severe end of that spectrum will be just complete suppression, no burst at all.
But you don't have a numerical value for that.
And so there is no scale. Nobody's looked at that as a continuous scale and tried to find if there's a gradation in the outcomes. And that's probably because first of all, you don't get enough patients that have enough burst suppression to use a sliding scale like that. And secondly, even if you did, I'm not sure if the interval itself may help much. And that's because at least for the first 24 hours, when you have targeted temperature management happening, the sedatives themselves will cause an interburst interval, will cause burst suppression to develop. And then what there is literature for actually, which reminds me as I was talking, that longitudinal EEG, which actually looks at the evolution of the pattern. So if you see a burst suppression pattern morph into a more continuous background, that seems to have a prognostic value. Actually, so maybe along those lines, it's possible that maybe if you see the interburst interval reducing on its way to a continuous background, it may suggest a good outcome, but there's no study to say that. Conceptually, I see what you're saying.
Yeah. So anyway, I mean, I think we will stop at this point. Thank you, Kartavya. I mean, that was really something. And let's see how this goes on, because it looks like we are not going to have conferences for quite a while. So we might ask you for more stuff on neurocritical care.
Absolutely.
At some stage, and we'll be in touch. Thanks a lot for this. Sudhir,
no problem.
Sudhir, you have anything? Where is Sudhir? Yeah, I think. So we are done. Thank you so much.
Thank you.
Bye.